So I am very happy to participate in this mentorship with our friends from Egypt and our friends from Yemen. And we will talk about the topic of systemic disease and cardiac involvement. So I will talk especially about liver disease. I would like to say that liver disease evolves into a multi-organ syndrome, and the physiopathology of this pathology, that the course of liver disease includes a clinically silent phase. It's about composite cirrhosis, but after that we will get a persistence of portal hypertension that will result into portosystemic shunting and decline in the metabolic and immunological function of the liver. After a few months to years, we will get an increase of circulating levels of vasodilators that escape from the splanchnic into the systemic circulation, causes a drop in systemic vascular resistance. And the lack of an immunological barrier leads to the translocation of bacterial products from the gut, further augmenting splanchnic and systemic vasodilatation. Another point that we will get also during liver disease, anatomic dysfunction with the progression of the liver disease, and that will cause hyporeactivity of the cardiovascular system to adapt to splanchnic and systemic vasodilatation. We will get also a hyporeactivity of the cardiovascular system coupled with the systemic vasodilatation, and all that will reduce the effective blood volume, which triggers the renin-angioaldosterone system and leads to sodium fluid retention. The results of all this point and all this modification will be the increase of heart rate, the increase of cardiac output, and the increase of plasma volume in order to maintain adequate organ perfusion, leading to hyperhemodynamic syndrome. However, hyperdynamic syndrome often becomes clinically evident only after the triggering event, for example, bleeding esophageal various acids, hepatic encephalopathy, or infection known as the composite cirrhosis. So if we try to summarize, the consequence of liver disease will be multi-organ lesion, as we know that it will be, we will get cardiopulmonary complication, we will get also renal complication, we will get even cerebral complication. But we talk about cardiopulmonary complication. As you see in the slides, we will get two mechanisms or two breed syndrome. The hepatopulmonary syndrome, which is defined by the trait of liver disease, intrapulmonary vascular disease, arterial desoxygenation, as you see here, and the second syndrome, the second biggest syndrome, is the portopulmonary hypertension, which consists of 3 points: the portal hypertension, the mean pulmonary arterial pressure increase, and pulmonary vascular resistance increase. And if we look to the three main syndrome, the hyperdynamic syndrome, the cirrhotic cardiomyopathy, and the portopulmonary hypertension, we will notice that there will be an increase of cardiac output for hyperdynamic syndrome. It's the first phases of cardiac disease during liver disease. The second point, where we get cirrhotic cardiomyopathy, we will get a decrease of cardiac output, an increase of resistance, mainly pulmonary vascular resistance, and an increase of pulmonary arterial pressure. The same thing for the portopulmonary hypertension. We will get an increase of pulmonary arterial pressure and an increase of pulmonary vascular resistance, but a decrease of cardiac output. So we talked about the liver, the cardiac disease during liver disease, the pulmonary disease during liver disease, but also there is cardiac syndrome in liver disease. as you see here, that cardiogenic liver injury, mainly when we get a sudden arterial hypoperfusion, we will get a lesion of liver. Also, when we have a long-term congestive cardiac disease, that will result into congestive hepatopathy. For cirrhotic cardiomyopathy, as you see, in advanced stage, the liver disease will result into splanchnic and systemic vasodilatation, disruption of immunologic barrier, good bacteria translocation, and autonomic dysfunction, evolving into a multi-organ syndrome affecting the heart, lungs, kidneys, and brain. So as you see, the modification or the functional changes in hemodynamics of liver will result into an increase of heart rate, of cardiac output, of plasma volume, and after that will that will define the hyperdynamic syndrome. After few years, we will get a remodeling of the cardiac muscle and even a dysfunction, and that will define the cirrhotic cardiomyopathy. So according to the last definition published in 2020 about cirrhotic cardiomyopathy, to define systolic dysfunction, we will get one of these criteria, either resting LVF less than 50% or an absolute global longitudinal rate less than 18% with no prior cardiac disease. For diastolic function, and according to the last definition, we have to get 3 or more items from the following items. As you see, septal velocity minor than 7 centimeter per second, or the ratio of E and E prime more than 15, a large volume of left atrium, or velocity of tricuspid regurgitation more than 2.8 meter per second. So in summary, if you will have a look about the recommendation of treatment of cardiac syndrome in liver disease based on current evidence, for cirrhotic cardiomyopathy, of course, we should treat patient with restriction of sodium intake and diuretic therapy. Also, if patient develops acids, that we will need loop diuretic and aldosterone antagonist at natriuretic dose. Patient with cirrhotic cardiomyopathy and grade 3 acid should be treated with large volume paracentesis. Also, we may use beta blockers, especially those who get based evidence medicine, especially carvedilol, but we should not use ERB or SAE during patient with decompensated cirrhotic. For portopulmonary hypertension, we advise drugs with shown benefit in treatment of pulmonary artery hypertension, and the goal of the treatment is to keep a normal level of pulmonary vascular resistance and also a normal level of PAP. And all patients with portopulmonary hypertension should be monitored closely and periodically evaluated for liver transplantation. Also, for patients who developed atrial fibrillation and liver disease, we know that we should anticoagulate this patient. NOAC are preferred over the vitamin K antagonist for prevention of thromboembolism in this patient, but we should be careful. NOAC are not recommended in child blood class C and should be used with caution in child blood class B. For apixaban, for rivaroxaban, we know that even the child blood class B is a contraindication. In patients also with metabolic dysfunction associated fatty liver disease, we should control all cardiovascular risk, especially those which are modifiable, like obesity, like diabetes, like dyslipidemia and hypertension. And when indicated, statins should be given at their conventional doses in patients with composite cirrhotic, and we should be careful. Statins should be avoided in patients with acute liver injury and decompensated cirrhosis or child blood class C. For congestive hepatopathy, we should use also diuretic therapy. We should switch from ECA or ARB to sacubitril valsartan in patient who develops heart failure, regardless of ejection fraction. And patient with congestive hepatopathy due to severe tricuspid regurgitation should be evaluated for transcatheter or surgical valve therapy. Patient with congestive hepatopathy and heart failure with HASD should be treated with combination of loop diuretics and aldosterone antagonist at natriuretic dose. For cardiogenic liver injury, it means for patients who get low cardiac output and that will result in a low perfusion of liver. The initial therapy is the correction of the underlying cardiac, circulatory, or pulmonary failure, the cardiogenic shock, for example. For acute heart failure, we should treat the overload, the volume overload with diuretics, and we also may introduce tonicardiac like norepinephrine or other vasopressor.
Okay, بسم الله الرحمن الرحيم. شكرا جزيلا. يعني a lot of thanks for my colleagues, Dr. Rania, Dr. Sam, Dr. Samah, Dr. Bushra, for all the effort والجهود الطيبة. My talk today it is going with the link between the diabetes and heart disease. First of all, we would like to know what about the diagnosis of the diabetes mellitus in the elderly. We will see in this slide that the increasing with the age, the incidence of the diabetes mellitus would be more. On the other hand, the people with diabetes mellitus are 2 to 4 folds times more likely to die from heart disease than people without diabetes. Okay, heart and diabetes, we will see that increased risk of heart disease by 2 to 3 folds in diabetic patient. In 2011, they implemented by stent 30% of the patient, 280,000 which have a heart attack annually. Higher heart disease morbidity and mortality rates 2 to 4 folds, and 60% chances of the dying from the heart disease in diabetic patient. So as a basics, we know, and all of us, we know that diabetes mellitus can lead to ischemic heart disease. Diabetes can induce hypertension. Diabetes can induce dyslipidemia. Diabetes mellitus can induce chronic kidney disease, and diabetes mellitus can induce peripheral artery diseases. As we know that diabetes mellitus is it is important because in the present of the silent ischemia of the ischemic heart disease because of the impaired of perception and neurological neuropathy. It is well known that hypertension, diabetes, or hyperlipidemia, if anyone, none of any one of these three, the incidence was 6 to 1 for 1,004 years. While if there is one of the two, hypertension or diabetes, it's 14 to 15 per 1,004 years respectively. But when both factors, hypertension and diabetes, are present, that the incidence increased to the 48% per 1,000. Melina et al. Found that high prevalence of asymptomatic systemic depression in diabetic patient with essential hypertension. It's very important point that we'll see this patient with ST depression. The number of ST segment depression episode was significantly related to, like I said, hemoglobin. That's mean related to the HbA1c. We will see if it is high, ST depression, we will note that. Even the left ventricular mass and the monetary systolic and diastolic pressure variability and hypertensive peaks. So the complex connection we have to diabetic can cause increased production of free radicals, and on the other hand, reduced of nitric oxide both or that increase of the production of free radicals can cause mutation, which lead to the loss and damage of the cells, which is leading finally to the heart disease. While in the reduced nitric oxide, leading to the vasoconstriction and ischemic heart disease, and finally ischemic heart disease with cardiac or heart disease. What about the ischemic heart disease pathologies? We have 4 causes that will trace. First, and the most common is the atherosclerotic, which is the right side of the screen, which are with the risk factors leading to atherosclerosis. Second is coronary microvascular dysfunction. Third is inflammation, and fourth, vasospasm. So atherosclerosis is well known as the cause of the ischemic heart disease. Coronary microvascular dysfunction is also autism. These 2 are equal in the as a risk factor for heart disease. As regarding the inflammation, we will see if we will risk factors here. Is aging, obesity, smoking, and stress. That the obesity is always associated with diabetes mellitus. So it is 3 components of the pathology inducing ischemic heart disease. Cardiovascular disease and diabetes, we can see that endothelial dysfunction, number 1, which lead to the impairment of the nitric oxide production activity. 2, loss of vascular tone. 3, impairment of the repair mechanism. Also, increased platelet activation, which is leading to the thrombotic formation by increasing plasma fibrinogen, increasing platelet aggregation, decrease in fibrinolytic activity. Also, that changes in the black character, which may be greater amount of the lipid reach to the atheroma and increase macrophage infiltration and activation. Risk factors, common risk factors that the genetic, insulin resistant, dyslipidemia, obesity, or sharing with the development of diabetes mellitus and hypertension, which finally leading to the pathological changes in the cardiovascular disease as atherosclerotic endothelial dysfunction, micro or vascular inflammation, vascular fibrosis, arterial remodeling, which is the first atherosclerotic leading to because of the microvascular disease, and the others because of the microvascular diseases, which leading to the heart disease. What about the heart failure? It's permanently that HIF and diabetes mellitus and underlying mechanism is starting by the endothelial dysfunction from the left side, number 1, and myocardial stiffness, impaired insulin signaling, lipotoxicity, myocardial fibrosis, hyperglycemia with glycated end products, loss of metabolic flexibility, cell apoptosis. Diabetic cardiomyopathy as a consequence of the metabolic disorders. We know that nutritional or metabolic disorders like obesity or diabetes can lead to the metabolic or diabetic cardiomyopathy, which leading to both changes in structurally and functionally. Structurally may be reduced hypertrophy of the left ventricle, or ventricular dilatation, or fibrosis. While the functionally changes will be diastolic, systolic, and also loss of the myocardial cells. Mechanism, hyperglycemia cytokines increase of the RAS, induced aldosterone system, leading to the hyperinsulinemia, hyperlipidemia, and glycated products withdrawals. The effect will be alterate the calcium hemostasis, mitochondrial dysfunction, fibrosis, apoptosis. So the end result of all of these leading to the left ventricular hypertrophy, diastolic dysfunction, systolic dysfunction, which is ended by the heart failure. This diabetic cardiomyopathy, which is altered or caused by all of these factors, and insulin signaling, oxidative stress, inflammation, apoptosis, mRNA, epigenesis, AR stress, glycated products, fibrosis, RAS, and so on. So all of these are in summary and briefly that affecting the diabetes in both ischemic heart disease and heart failure as example. For summarize all the effect of the diabetes in this issue, this slide is summarized exactly and in briefly what the diabetes can do with the heart. If we see in the diabetes, in the right side, diabetes leading to the impaired glucose handling insulin resistance, will affect by autonomic dysfunction, and by other side, it will be oxidative stress. Oxidative stress, which leads inflammation. Inflammation will lead to fibrosis and to atherosclerosis, and also hypertension, which atherosclerotic leading to the coronary artery disease. Finally, inflammation can be finally ending by fibrosis, which is leading to the diastolic dysfunction and systolic function, which is diabetic heart failure. Now, what about the treatment? We will go fastly and quickly about the treatment of patient for the diabetes and heart disease. Firstly, we have to see and to confirm, is the patient has diabetes and cardiovascular or not? If it confirmed, we have type 2 diabetes mellitus and atherosclerosis present or not, or a patient with type 2 diabetes mellitus and heart failure. So the treatment, it will be different. If there is atherosclerotic and diabetes, we have to start with the GLP-1 receptor antagonist and sodium glucose transferase coeffector inhibitors. While in the heart failure, we will start with sodium glucose inhibitor only. What about the recommendation in the last guideline? We will go fastly. ممكن نتكلم عن التريتمنت دكتورة رانيا؟
كمل يا دكتور عادل.
Dr. Ahmed, yes,
سامعيني؟
yes.
سامعينك.
Okay. So what about the last recommendation in 2023 European Society of Cardiology recommendation? The first of all, if the patient is symptomatic, if the patient is asymptomatic without symptoms, you mean, and he is atherosclerotic or severe total organ damage, it is recommended to estimate 10 years. يعني مختصر انه we have to start to estimate the risk of the 10 years by score 2 diabetes اللي طلعت بالاخير. Number 2, we have to weight reduction with diabetes by the exercise, the types of the exercise as we know. Lastly, the bariatric surgery should be considered only if the patient has very high risk, body mass index more than 35 kilogram per millimeter, and when repetitive and structural effort of lifestyle changes combined with weight reducing medication do not result in maintained health. What we mean that bariatric surgery is indicated only if other managements are failed to reduce the obesity. As we said that physical activity and exercise, we have adept exercise, we have structural exercise, and structural exercise establishes cardiovascular disease like with is present of coronary artery disease, HIF-PIF, HIF-MRIF, and HIF-RIF. Or patient who has atrial fibrillation to improve the metabolic control, exercise capacity, and quality life, and reduce cardiovascular event. About the smoking, the advice to the replacement by some of the new drugs. Glycemic control, it is should be considered. Atherosclerotic cardiovascular disease risk reduction with glucose lowering medication in diabetic patient. الأولوية أو priority is used of the glucose lowering agent with proven cardiovascular benefits. Agent without proven proven by agent with the proven cardiovascular safety. That means that there is benefit and there is safety. So we have to take the first, which is important. In addition, glucose control needed. If the additional glucose control, this is strange شوية في الريكومنديشن الأخيرة إنه if the additional glucose control is needed, metformin should be considered in patient with diabetes 2 and atherosclerotic, which is 2A, not like before class 1 recommended. Blood pressure should be regularly measurement. What about the diabetic? As we know that the patient, diabetic patient can cause hyperlipidemia, particularly triglyceridemia and low HDL. BCSK9 inhibitor is recommended only at very high risk of the patient. All the كل المحاولات السابقة يعني فشلت إن تنزل ال LDE على التارجت. طب if statin basal regimen is not tolerated at any dose, even after the challenging PCSK9 inhibitor added to azithromycin should be considered. انتي ثرومبوتيك ثيرابي في البيشنت اللي عنده مجال طبعا نفس الكلام، وهي بانه خفض الدوز اوف ذا بي 2 بي in patient with acute coronary syndrome with diabetes undergoing a stent implantation and having an indication for anticoagulation following triple therapy with low dose of aspirin, clopidogrel, and oral anticoagulant. In patient with acute 2A, in patient with acute coronary syndrome or chronic coronary syndrome and diabetes undergoing coronary stent implantation and having an indication for anticoagulation following triple therapy with low dose may be considered. The important point الأخير اللي كانت بتطلع إنه when clopidogrel is used, omeprazole and esomeprazole are not recommended for gastric protection. Management of the coronary arteries in patients with diabetes in myocardial revascularization in chronic coronary syndrome is recommended when angina patient despite treatment with anti-anginal drugs or in patient with a documented large area of the ischemia more than 90% of the left ventricle. A complete revascularization is recommended in patients with ischemia without cardiogenic shock with multivessel disease. What about non-ischemia? Without any cardiogenic shock, it is the advice that revascularization as early as possible. Routine immediate revascularization of non-calibrate lesion in patient with the myocardial infarction and multivessel disease present with cardiogenic shock is not recommended. الهارت فيلير هو حقيقة هو نفس الكلام، نفس الانفستيجيشنز او نفس الدايجنوستيك تول، نفس الكلام اللي هو موجود في الهارت فيلير جايد لاين. Only heart failure is treatment in patient with diabetes and left ventricular ejection fraction more than 40. That the EMBA and DABA are recommended in patients with type 2 and diabetes 2 and the ejection fraction more than 40 or HFMRF and HFpEF to reduce the risk of the heart failure, hospitalization and cardio. Now we have three questions as MCQs, and it's up to you. If you like to read it quickly.
Dr. Ahmed, bravo, mais je pense le MCQ, not now.
Okay. So we will postpone it later on, inshallah. الو
أيوة
سامعني؟
أيوة سامعينك.
خير إن شاء الله. So any notes or any comment about the presentation? If it is, we can introduce it or?
No, very good presentation and especially the new recommendation. Thank you for this kind presentation, Dr. Ahmed.
Sorry.
Bravo, Dr. Ahmed.
شكرا
Congratulations. It was very nice.
شكرا لك. وانت يعني انت ما شاء الله يعني غطيتي الموضوع تغطية جميلة جدا، وفي حاجة جديدة عرفتها انا اول مرة اليوم هذا. ما شاء الله عليكي، ما شاء الله.
عايشك. We switch to دكتورة سماحة.
Okay.
Thank you.
You can put دكتورة سماحة as host.
Hello everybody, and thank you for this opportunity. So this is Dr. Farhat Sameh, and I'm an assistant professor in cardiology in cardiology department in Salou University Hospital, and I will talk about heart involvement in systemic immune-mediated diseases. So as an introduction, a multitude of systemic diseases can have significant effects on the heart, and importantly, cardiac manifestations can be the first sign of the underlying systemic disease or represent a complication secondary to the primary systemic disorder. The three layers of the heart as well as coronary arteries can be affected. modern sophisticated imaging techniques reveal cardiac abnormalities in most of these diseases. And in fact, the reported frequency of cardiac involvement ranges widely, depending upon the applied diagnostic methods and selection of patients. So, understanding the cardiac manifestations of commonly encountered diseases is critical, as treatment can often alleviate their cardiovascular manifestations. So, the European Society of Cardiology proposed classification of 5 groups of systemic inflammatory diseases. In fact, systemic immune-mediated diseases include autoimmune and autoinflammatory diseases affecting at least 2 organ systems. Autoinflammatory diseases refer to a growing family of conditions characterized by episodes of unprovoked inflammation in the absence of high antibody titers or autoreactive T lymphocytes reflecting a primary innate immune system dysfunction. Conversely, autoimmune diseases are characterized by aberrant B, T, and dendritic cell responses leading in a break in tolerance against self-antigens with predominantly cell-mediated or autoantibody-mediated responses in genetically susceptible individuals. In fact, this dichotomous classification does not reflect clinical evidence, and the continuum from purely autoinflammatory to purely autoimmune diseases should be, in fact, considered. So, talking about pathophysiology, the hypothesized pathogenesis encompasses different mechanisms, but only some of these have been clarified. The heart can be primarily involved or can be indirectly damaged by chronic inflammation, other injured organs, and by drugs used to manage the primary disease. About the second algorithm, we can see that traditional cardiovascular risk factors, disease-related factors triggered by the dysregulation of innate immunity and the current and cumulative inflammatory burden, act synergistically and promote the pathophysiological processes of endothelial dysfunction, arterial stiffness, and oxidative stress, leading thus to an accelerated atherosclerosis and subclinical micro and macrovascular damage. So, cardiac involvement is there is very wide, and all layers, as we said previously, of the heart can be affected. In fact, it can be presented either as pericarditis, myocarditis, or myocardial fibrosis, coronaritis with ischemic heart disease, endocardial involvement with valvular disease and formation of thrombi. We can see also pulmonary hypertension secondary to concomitant lung disease or recurrent lung embolism. Unexplained arterial thrombosis. It's frequently associated with antiphospholipid syndrome. We can see syncope, and it's related to conduction abnormalities or arrhythmia, and arterial hypertension. And the percentage of each manifestation is variable depending of the pathology. So, diagnostic tool or approach, there is many tools, and we begin first by clinical features. So, generally, clinical presentation is unspecific, but red flags may include unexplained dyspnea, palpitations, chest pain, syncope, arrhythmia, and acute or chronic congestive heart failure, aborted sudden cardiac death, or fulminant cardiogenic shock. So, at diagnosis tool, we can use biomarkers, and they should not be done routinely, but only if clinical suspicion of cardiac symptoms or there is signs that are developed by the patient. and majorly an increase in troponin or the NT-proBNP may be indicative of myocardial involvement. So, as I said, the use of biomarkers should be adapted according to the current ESC heart failure guidelines, algorithm, and cutoff values. So, EKG, we may notice abnormality on standard 12 lead electrocardiography or on Holter monitoring. So, echocardiography is essential in diagnosis of pericardial valvular involvement. It is in fact the first line method in standard echocardiography with Doppler analysis, as well as advanced methods as deformation imaging that detect subclinical myocardial involvement. We can use also transesophageal echo, particularly in association with 3D mapping or imaging, and it may be useful in particular cases such as Liebman-Sachs endocarditis. So echo should be performed in all inflammatory diseases with suspected cardiac involvement. So a CMR in cardiac involvement in inflammatory diseases can be assessed by CMR tissue characterization with T1 or the T2 weight imaging and late gadolinium enhancement, as well as with the parametric mapping. And the characteristic subepicardial or mid-myocardial late gadolinium enhancement pattern seen in inflammatory diseases allows differential diagnosis from coronary artery disease from ischemic and non-ischemic cardiomyopathy, in fact. So CMR should be considered in certain cases and uncertain cases, and where myocarditis or myocardial infiltration is suspected. So talking about CT, it is mainly used for the diagnosis of aortic disease and coronary atheroma, as well as pericardial disease, if other tests or imaging modalities fail to provide sufficient information. And the CT shows coronary and aortic calcification. It can substitute invasive coronary angiography in some cases. PET scan or nuclear imaging is particularly useful to detect inflammation in specific settings, such as sarcoidosis, and it is particularly used to detect inflammation. So I'll talk now about endomyocardial biopsy. It is the gold standard for suspected myocarditis with or without associated inflammatory diseases. And in addition, it can identify cardiac vasculitis and or other non-inflammatory degenerative or infiltrative myocardial diseases. It is shown also that EMB has a low complication rate of 0.8%. And it has a significant clinical value provided that it is taken by experienced investigators. So I talk now about general principles of management of cardiac involvement systemic immune-mediated diseases. In fact, there is control of inflammation and disease activity. There is 3 targets of treatment. It's control of inflammation and disease activity, lifestyle modification, educational and behavioral interventions, and treatment and the control of cardiovascular comorbidities. So immunosuppressive treatment, complications, Hello?
معاك الدكتورة سامية. معاك. دكتورة سماح.
Hello.
Yes.
تسمع فيها؟
Hello. Hello.
أي نسمع فيك.
تسمع فيها؟
أي نسمع فيك. نسمع
لا
فيك.
لا، نسمعك. سامعينك دكتورة سماح. سامعينك.
Okay, so I said that the role of disease-specific therapies, background disease-specific therapies in SIDS include immunosuppressive and/or immunomodulatory regimes, particularly in active phases of the disease. And these regimens are tailored to the level of disease activity, the involvement of vital organs, and the presence of comorbidities with a personalized approach. When a vital organ failure ensures general supportive management is used, and in many inflammatory diseases, proven myocarditis is an indication to a more intensive immunosuppression, since it may lead to irreversible organ damage and directly affect survival. So, as a cardiologist, we should know every effect of each medication used in these diseases. And immunosuppressive treatment complications, in fact, include a higher incidence of acquired infections or reactivation of latent or opportunistic infections. The use of corticosteroids is associated with adverse cardiovascular outcomes and an unfavorable metabolic profile, especially related to high dose and prolonged use. Therefore, in most cases, steroid-sparing strategies are preferred. Finally, we should know that teratogenic and oncogenic effects of some immunosuppressants, as methotrexate, should be minimized, and active screening programs are advisable in this high-risk population. We should know then that, for example, hydroxychloroquine or disease-modifying anti-rheumatic drugs or methotrexate have, in fact, positive effects on cardiovascular outcomes and an improvement in metabolic syndrome components. So to conclude, cardiac involvement is a very common comorbidity of systemic autoimmune diseases. It greatly contributes to a general deterioration of patient health status and to higher mortality rate in comparison to general population. And management of patients with medication should always include cardiological screening and follow-up in patients with clinically suspected cardiac involvement.
Hello everybody. Heart Academy of the Egyptian Society of Cardiology, a collaboration between Egypt, Tunisia and Yemen. Of course we know that heart disease kills one person for every 33-second interval nationwide. My presentation is about heart and systemic diseases. This is Gamila Nasr, Professor of Cardiology, Suez Canal University, Egypt, Head of Scientific Council of the Egyptian Board of Cardiology, Board Member of the Egyptian Society of Cardiology, Africa Continent Representative in the International Society of Cardiovascular Disease Prevention. Importance of understanding the relationship between systemic disease and the cardiovascular health is really very important. There is a wide variety of systemic diseases that may affect the heart by a number of different mechanisms, including increasing demands on the heart, causing arrhythmias, affecting the structure of the heart, or promoting cardiovascular disease and therefore coronary heart disease. Chronic kidney disease is one form of systemic disease that may affect the heart. As we all know that chronic kidney disease has a definite relation between heart and the impact of chronic kidney disease on the structure causing hypertrophy, on the other mechanisms causing a lot of changes, and maybe the complications of chronic kidney disease is very well known. Another common association with systemic disease include endocrine and metabolic disease. For example, diabetes, very, very well-known relationship, causing coronary artery disease, causing cardiomyopathies, congestive heart failure, hyperthyroidism as well, causing supraventricular tachycardia, AF, hypertension, hypothyroidism, causing bradycardia, dilated cardiomyopathy, heart failure, pericardial effusion. The very well-known relationship between diabetes and heart, causing by the hyperglycemia, free fatty acids, insulin resistance. All these are doing some form of oxidative stress, leading to vasoconstriction, leading to inflammation, thrombosis, and this very important manifestation of diabetes on the heart, the diabetic cardiomyopathy, affecting the heart muscle, the vessels, impact on coronary vessels, leading to endothelial dysfunction, leading to stiffness, increased arterial stiffness, leading coronary artery calcification, accelerated atherosclerosis, as well as doing autonomic impact, leading to reduced heart rate variability, increasing resting heart rate, arrhythmias, and the impact on the cardiac muscle, leading to diastolic dysfunction, systolic dysfunction. This very ugly looking artery, leading to atherosclerosis and having a lot of complications on the vascular system. And this is very important and very ugly complications, leading to a lot of complications as well. Also, we do have other complications, as we know that the cardiovascular risk for diabetes is very specific. There is microalbuminuria, this is massive proteinuria, the platelet function abnormalities, the serum insulin, the thrombotic levels as well. Other association rather than diabetes, the hyperthyroidism, the hypothyroidism. The hyperthyroidism, by a lot of mechanisms, leading to supraventricular tachycardia, AF, and hypertension. The hypothyroidism, the other side of the coin, leading to bradycardia, dilated cardiomyopathy, heart failure, pericardial effusion, has an impact on dyslipidemia, the intima thickness, the blood pressure, and leading to heart failure. Other associations with systemic diseases include the malignant carcinoid, the pheochromocytoma, the acromegaly, the hemochromatosis, the Anderson-Fabry's disease, malignant carcinoid leading to tricuspid pulmonary valve disease, right side heart failure, pheochromocytoma leading to hypertension, tachycardia, congestive heart failure, acromegaly, heart failure, hemochromatosis, heart failure, again, arrhythmias, heart block, Anderson-Fabry disease leading to arrhythmias, coronary artery disease, heart failure. We all know that the carcinoid affecting mainly the tricuspid and pulmonary valve disease, leading to heart failure by different mechanisms. On the other hand, pheochromocytoma mainly lead to hypertension and tachycardia, leading to congestive heart failure at the end. The acromegaly increased growth hormone, leading to sustained lipolysis, insulin resistance, increased liver and kidney gluconeogenesis, reduced glucose uptake in adipose tissue and muscle tissues. These all lead to increased lipid, increased triglycerides, decreased HDL, diabetes, heart failure. Other systemic disease include nutrition, malnutrition, leading to dilated cardiomyopathy, heart failure. For example, vitamin deficiency as thiamine deficiency, leading to high output heart failure, dilated cardiomyopathy, hyperhomocystinemia, leading to premature atherosclerosis, obesity, definitely leading to cardiomyopathy and heart failure. And this is the obesity heart disease, a very common disease, and we should prevent it by many means. We all know that the obesity has definitely an impact on heart. Other multi-system disease, the rheumatoid arthritis, leading to pericarditis, pericardial effusion, coronary arthritis, myocarditis, valvulitis, seronegative arthropathies, leading to aortitis, aortic and mitral insufficiency, conduction abnormalities, systemic lupus, pericarditis, Liebman-Sachs endocarditis, myocarditis, thrombosis, both arterial and venous. This is rheumatoid arthritis. As we know, it's definitely has a definite impact on the heart, leading to ischemic heart disease. Maybe many patients of having rheumatoid arthritis complain silently of symptoms of heart disease, and many of them experience ischemic heart disease in a silent form. Systemic lupus, very famous to cause vasculitis, pericarditis, Liebman-Sachs endocarditis, myocarditis, thrombosis, which is both arterial and venous. Other systemic disease like amyloidosis, heart disease, heart failure, restrictive cardiomyopathy, valvular regurgitation, pericardial effusion, sarcoidosis leading to heart failure, dilated restrictive cardiomyopathies, ventricular arrhythmias, heart block. Marfan syndrome mainly affects the aorta, leading to aortic aneurysms, dissection, aortic insufficiency, mitral valve prolapse is a very common association. Ehlers-Danlos syndrome leading to aortic and coronary aneurysm, mitral valve prolapse. HIV infection, myocarditis, dilated cardiomyopathy, pericardial effusion, amyloidosis effect definitely have an impact on the heart, leading to heart failure, restrictive cardiomyopathy, valvular regurgitation, pericardial effusion. We have many kinds of amyloidosis, primary, secondary, senile. Sarcoidosis, of course, leads a disease which has an impact on heart, leading to heart failure, dilated restrictive cardiomyopathy, ventricular arrhythmias, heart block. Marfan syndrome, it has an impact on the aorta. As we can see, may lead to aortic aneurysm. This is the ascending aorta, and may lead to dissection, aortic insufficiency, mitral valve prolapse. And lately, the COVID, we have noticed a lot of patients having hypertension, and it has led to thrombosis, thrombosed vessels, and many other impact on the heart disease as well. So my conclusion is that a holistic approach to managing systemic disease and their cardiovascular implications is needed, and definitely we need to have a preventive approach by this very nice equation coming from the European Society of Cardiology, 035140530. People who stay healthy tend to have certain characteristics. 0 stands for no tobacco. 3 walk 3 kilometers daily or 30 minutes on any moderate activity. Take 5 portions of fruits and vegetables a day, being antioxidants as well as healthy diet. 140, keep your blood pressure ample amount, as well as the lipid should be total cholesterol less than 5 millimole, LDL less than 3 millimole, and 0 avoidance of overweight and diabetes. Thank you very much. We tried as we can do to put this subject in a nutshell and in a very few words to explain the systemic disease and its impact on heart disease. Thank you very much.